Okay, so we are going to do Doppler effect. You guys want the lights off? Yeah. All right, so we're going to do Doppler echocardiography today. We're going to look at what's a Doppler effect, the Doppler shift formula, spectral recording, what the spectral recording looks like, the pulse wave Doppler, what is pulse wave Doppler, what is continuous wave Doppler, and then color flow Doppler. Remember, Doppler is the backbone of echo. You have two-dimensional echo, which is the images that you're accustomed to seeing, and then Doppler echo. Doppler allows you to calculate gradients across structures, across valves, and to allow you also to calculate valve area. So it's extremely important. So if you have like a atrial septal defect or a ventricular septal defect, you can calculate the gradient across that defect. And not only that, there's something we call shunt flow. That is how much blood is shunted across the defect. You can use Doppler to do that. So Doppler is extremely important. So you should try your level best to understand. It's not difficult. Okay. All right. So the Doppler effect was first proposed by an Austrian physicist, Christian Doppler, in 1842. And he was just observing what was happening around him. What he observed that when a train was coming towards him and the horn was blaring, it it appears that the intensity was greater, and then when the train passed, the intensity get less. So that's common sense, right? It's nothing. I mean, you observe that. If you're on the road and you stand and a car is blowing the horn, when it's coming towards you, it appears louder. When it passes, it just appears lower, not as loud. So that's the Doppler effect. So that's it, nothing more. But you have to understand what's going on there. The frequency. So let's use the train situation. The frequency of the horn that the train is producing train on, the frequency is the same. The frequency is not changing because if they press a button to produce the horn effect, then that frequency is the same. It's just the perceived frequency that seems to be shifting because the object is moving. If the object is stationary, you have no Doppler effect. So if the source that's producing the sound is stationary and the observer is stationary, there's really no Doppler effect. The Doppler effect relates to if the source of the sound is moving. So when that source of the sound is moving towards you, there is a perception that the frequency is increasing. And then once it moves away from you, there's a perception that the frequency is decreasing, but the actual frequency is the same. Does that make sense? Yes. All right. So it took this guy, a physicist, to observe that. I don't know what people were doing before that. You just take it for granted. So this is what it looks like. So if the source of the sound is moving and if it's moving towards you, the frequency, the appearance frequency, not the actual frequency, if the frequency appears to be increasing. So if the frequency increase, remember we did the wave equation, right? Where the speed, that was one of the exam questions. The speed of sound or the speed of any wave is equal to the frequency times the wavelength. So if, say for instance, you're right here, say the observer is here, okay? And say the observer is right here. If the sound is the source of the sound is moving away, then the perceived frequency is less. And if it's coming towards you, then the frequency is more. It appears to be greater. So this sort of, all right. So what we have been saying is that when an object is moving towards the transducer, so now we're going to relate this to ultrasound. So the same thing. When an object is moving towards the transducer, the frequency observed is higher than the transmitted frequency. So, okay, so the same principle. So you're doing an ultrasound, say, of the heart, and you have the transducer there. And we usually, when we're talking about something moving, say we're using blood there. If the blood is moving towards the transducer, then the perceived frequency is going to be higher. The frequency that the transducer is producing is the same, but because the source of the sound is moving towards the transducer, which is like the observer, the perceived the frequency observed is higher than the transmitted frequency. Okay, and then when an object is moving away, so it's the opposite. When the object is moving away from the transducer, say the blood is moving away from the transducer, the frequency observed is lower than the transmitted frequency. Remember, the frequency that the transducer is producing is the same. It's just that you have another source of sound that's moving towards or away from the transducer. Does that make sense? Okay. So another very important point is that if the blood, because we're talking about the structure, because you can have, blood. We use mainly blood when we're doing Doppler echo, or we can use, structured valves. But if the blood is moving towards the transducer, we say that the observed frequency is going to be higher. Usually that's depicted as above the baseline. So that envelope is going to give you a spectral display. So we call that a spectral display. You're going to get a spectral display above the baseline if the blood is moving towards the transducer. If the blood is moving away from the transducer, it's going to give you a spectral display below the baseline. So those are principles that you have to get. All right. And so we talk about a Doppler shift. What is Doppler shift? We talk about the received frequency, that is the observed frequency, and then the transmitted frequency. The Doppler shift is the difference between them. Okay, so remember, in the case of the observer with the train, when the train is coming towards the observer, there's an observed or a received frequency which appears to be higher. So that is what we call the received frequency. But the actual frequency, what the horn is producing is the same. It's not changing. So that's a transmitted frequency. And the Doppler shift is equal to the received frequency minus the transmitted frequency. Remember, if the source of the sound is moving towards you, if you have the transducer on the chest and the blood is moving towards the transducer, it's going to produce a spectral envelope above the baseline. If the blood is moving away from the transducer, it's going to produce a spectral display below the baseline. Okay? Remember, you have received frequency and the transmitted frequency. You have to have a clear distinction between those two frequencies. Okay? So the transmitted frequency is a fixed frequency, but because a source is the source of the sound is moving away or towards an object, you have a receive frequency or observe frequency. Okay? So you can write the Doppler shift formula, and you can, so you'll see this in your textbook and elsewhere, that the Doppler shift formula is equal to 2 times the observed frequency times v, which is the velocity of blood, times the cosine of the angle between the beam transmitted from the transducer and the moving red blood cells, and c is the velocity of sound in blood. Let's analyze the formula a little bit. Okay, so what we're saying is the Doppler shift is equal to 2 times the transmitted frequency. That's whatever frequency you're using. Now, when we're doing ultrasound, we have the transducer on the chest, and it's producing an ultrasound beam towards, say, so we're looking at blood flowing across the mitral valve. Okay? If we're looking at blood flowing across the mitral valve, it's going to come from the left atrium, across the mitral valve, into the left ventricle. And if we have our transducer, say the transducer is at the apex, right? So the blood will be moving towards the transducer. Yeah. So we expect to get a Doppler shift, or a spectral envelope above the baseline, right? Because it's moving towards the transducer. Okay. So this formula says that the Doppler shift is equal to 2 times the transmitted frequency, v, which is the velocity of the moving blood, okay? So it has a speed, times the cosine of the angle between the ultrasound beam and the red blood cells. Because the blood is moving, so there's an angle, because the ultrasound beam is, you can use like a straight line to depict that. So there's an angle there, divided by c, which is the velocity of blood, velocity of sound in blood. Remember, that the velocity of sound in blood is fixed. The velocity of sound, that was also an exam question. The velocity of sound in soft tissue is 1540 meters per second. And it's similar for blood. Very important observation here. The cosine of 0 is 1. So you will get your maximum Doppler shift at 0 degrees when the ultrasound beam is parallel. When the ultrasound beam is parallel to the moving blood or red blood cells. Does that make sense? Because maximum Doppler shift, anything greater than that is going to give you a smaller number. Agree?
So anything greater than cosine of 0?
Yes. It's going to give you a smaller,
less than 1.
Less than 1, yeah. Okay. So the maximum Doppler shift is 0. So you want to get that ultrasound beam as parallel to the moving red blood cell as possible. And that is why we always tell you, if you're looking at any structure, try and get the ultrasound beam parallel to the structure, parallel to the blood flow as much as possible, unless you're going to get a lower velocity. So another very important principle, when you're doing ultrasound, you have to get your ultrasound beam as parallel to blood flow as possible. Above 20 degrees, it's not accurate because you're reducing the Doppler shift too much. So at 90 degrees, what Doppler shift you expect to get? Cosine of 90 is 0. So you're not going to get any Doppler shift. So if you, say for instance, you looking at blood flow across the mitral valve, if your ultrasound beam is perpendicular to the flow, you're not going to see anything. It's not that it's not there, it's just that your angle is not adequate. You have to get that angle as parallel as possible to blood flow, looking at the Doppler shift formula. Okay? So the Doppler shift formula, you should try and memorize it a little bit. It says equal to the transmitted, 2 times the transmitted frequency times V, which is the velocity of the moving red blood cells, cosine of the angle between the ultrasound beam and the moving red blood cell, and divided by the speed of sound in blood. Okay? You have to get your ultrasound beam parallel to flow as possible. Okay, so this depicts it using this animation a little bit clearer. So if the blood is moving towards the transducer, well, we said that the perceived frequency increase, and you can see if the frequency increase, then it bunches up, right? So if the frequency increase, then the wavelength gonna decrease, because the speed of sound in any media is constant. So if the frequency increase, you expect the wavelength to decrease, right? So the blood is moving towards the transducer. So we have the wave here. So the wave, you see, it bunches up, multiple crests. So when it's moving away from the transducer, the frequency decrease. You see that? The frequency decrease. It's less, the bunching up is less, but the wavelength increase. Because the product of frequency time wavelength is constant for any media. So that's one way of showing that the frequency increase in the top scenario, and then in the bottom scenario, the frequency decrease. Blood moving towards the transducer gonna give you a perceived increase frequency. Blood moving away from the transducer, it's gonna give you a perceived decrease frequency. The transmitted frequency is the same. It's a Doppler principle. Okay, all right. And this is what I was trying to show you. So when the ultrasound beam is coming down, okay, comes down a straight line because the sound, even though it's a wave, and then the red blood cell is moving, say it's moving towards the transducer somewhat. There's an angle between the moving red blood cell and the ultrasound beam. That's the angle we're talking about, theta. So if theta is 0, we get maximum Doppler shift. And then if theta gets anything greater than 0, the Doppler shift gets less. So you want to get your ultrasound beam as parallel to blood flow as possible. Because in that situation, theta is 0, the cosine of theta is 1. Cosine of 90, cosine of 0 is 1. Cosine of 90 is 0. Right? All right. So when we do spectral velocity recording, okay, the flow velocity towards the transducer is displayed as a positive or upward shift in the velocity. So what we're saying is that it's going to give you an envelope above the baseline. So the flow velocity towards the transducer is displayed as a positive or upward shift. It's going to be above the baseline. And the flow velocity away from the transducer is displayed as a negative or downward shift in the velocity. It's going to be below the baseline. So blood flowing towards the transducer, above the baseline and positive. Blood flowing away from the transducer, it's going to be negative or below the baseline. And this is what it looks like. So in the first scenario, the blood is flowing towards the transducer, so it produces a spectral envelope above the baseline and positive. Okay, so the baseline is right here. Okay, this is the baseline, and this is the spectral envelope, which is above the baseline because the blood is flowing towards the transducer. In the second scenario, the blood is flowing away from the transducer. This is a transducer. So it produces an envelope below the baseline and negative. Okay? Let's look at the actual scenario. So when you look at this, this is a short axis at the level of the aortic valve. So it's a short axis at the level of the aortic valve. This is the tricuspid valve right here. Okay? If you have tricuspid regurgitation, if you remember your scan and view lecture, then right up here, this is the right ventricular flow tract, tricuspid valve, and this is the right atrium. If you have tricuspid regurgitation, then blood is flowing from the right ventricular flow tract across the tricuspid valve into the right atrium, right? So this usually depicts where the transducer is. So there is always a little symbol to tell you where the transducer is. So this is your transducer right here. Okay? So if in tricuspid regurgitation, the blood is flowing from the right ventricular flow tract across the tricuspid valve into the right atrium. So the blood is moving away from the transducer. Does that make sense? It's moving away from the transducer. So the spectral envelope that it produces is below the baseline, And it's a systolic flow. Tricuspid regurgitation is a systolic flow because it occurs in systole when the tricuspid valve is supposed to be closed. But because the valve is incompetent, then blood is flowing across the valve in systole when it's supposed to be closed. And if you look at your ECG on top here, systole is from the QRS to the T wave. So you get these systolic envelopes. See that? But they're below the baseline because the flow is away from the transducer. So flow away from the transducer is below the baseline and negative. And then in this case, it's tricuspid regurgitation. It's a systolic flow. So it occurs in systole. Remember, systole is from the QRS to the T wave. Let's look at this one now. So, and of course, this is the cursor. Okay, this is the cursor. This is a 4-chamber view on top. 4-chamber view with the left ventricle. The mitral valve is right here, left atrium. This is the sample volume right there. So we're sampling across the mitral valve. We are sampling across the mitral valve. Remember that blood flow from the left atrium across the mitral valve into the left ventricle, but it does so in diastole. But again, our transducer is right here. Sample volume is there. The blood is flowing from the left atrium across the mitral valve into the left ventricle. It's flowing towards the transducer. So you get this envelope in diastole. So it's above the baseline and positive. but it's in diastole. So flow across a mitral valve is a diastolic flow, and it's above the baseline because the flow is towards the transducer. Any question there? Okay.
So if it's, say, in diastole, is it always going to be above the baseline then?
If it's flowing towards the important point there is if it's flowing towards the transducer.
Okay,
Yeah.
so it could be insystole or diastole, just as long as it's flowing towards the transducer.
But the normal flow across the mitral valve is in diastole.
Right.
If it occurs in systole, then it's mitral regurgitation. And in that situation, it's going to be below the baseline, away from the transducer. Yeah. So you can just look at the baseline and see whether it's flowing towards or away from the transducer. And then you can look at the ECG to say, is it a systolic flow or a diastolic flow? Okay. All right, so this is our Doppler shift formula. And so you, again, we're going to stress the point. You want the flow as parallel. You want your ultrasound beam as parallel to flow as possible, so you get maximum Doppler shift. Cosine of 0 is 1. Cosine of 90 is 0. So that's basically what we're trying to show here. So when an ultrasound beam is parallel to blood flow, the angle theta is 0 and the cosine of 0 is 1. That's the maximum velocity or true velocity. When an ultrasound beam is perpendicular to blood flow, the angle theta is 90 degrees. Cosine of 90 degrees is 0. Thus the velocity will be 0. So if your ultrasound beam is perpendicular to flow, you're not going to get any velocity. It's important to remember that, no velocity. So always assess Doppler in multiple windows. This is a very important statement. Always assess Doppler in multiple windows to get the most parallel beam to blood flow, and hence the maximum velocity. So you cannot just use one window, just one area on the chest, and hope that the flow there is going to be, or the ultrasound beam is going to be parallel to flow. It might not be, because everybody's heart is different, everybody's chest is different. So you should assess flow on multiple windows. Okay? And that is why we do echo from multiple sites. Okay? We want to get ultrasound beam parallel to the blood flow as possible. Okay. All right, so that's Doppler in a nutshell. And once you remember, if the source of the sound is moving and it's moving towards you, the perceived frequency seems to be higher. Once it moves away, the perceived frequency seems to be less. That's a Doppler. If the blood is flowing towards the transducer, it's above the baseline. Moving away from the transducer, it's below the baseline. We have 3 types of Doppler that we look at in echo. We have the pulse wave Doppler, continuous wave Doppler, and color flow Doppler. Color flow Doppler is a form of pulse wave Doppler. So whatever we say about pulse wave Doppler, color flow Doppler also applies. And then we also have tissue. Doppler imaging. So I didn't put that here, but we have that lecture separate. TDI, tissue Doppler imaging, where we actually look at the movement of tissue. This is a form of pulse wave Doppler. It's just that the velocity is usually much lower than, say, the movement of blood. But tissue Doppler, TDI, is a form of pulse wave Doppler as well. Okay, so pulse wave Doppler measures the velocity of blood at a single point. The transducer sends out a signal and then waits for a reflected signal. So what the transducer does, it sends out a pulse, and then it waits. It doesn't send out multiple pulses. Send out one pulse, and then it waits for that return signal. And that's what we call a pulse wave Doppler. The problem with that, the transducer is alternating between the transmission and the reception. Okay? And because it's doing that, it can only assess low velocity. So pulse wave Doppler is used to assess low velocity, usually below 1.5 to 2 meters per second, because it sends out an impulse and then it waits for that impulse to come back. So example of flow that we use pulse wave Doppler to assess is mitral inflow. So the flow from the left atrium across the mitral valve to the left ventricle, which is a normal flow across the mitral valve and diastole, we use pulse wave Doppler because that's a low flow, usually less than 1.5 to 2 meters per second. The left ventricular flow tract, we use Doppler to assess the flow of blood going across the left ventricular flow tract. Very important. That's low flow as well, so we use pulse wave Doppler. It's usually less than 2 meters per second. Hepatic vein is also a low flow scenario, so we use the pulse wave Doppler to assess hepatic vein, and that's usually below 2 meters per second. Okay, so mitral inflow, left ventricular flow tract, and hepatic vein. So when we're doing the hepatic vein, if you remember your anatomy, that's a subcostal view, and we see the IVC, and the hepatic vein joins the IVC. So we'll just put the Doppler there, and it's important. In the further lectures, you'll see the importance of assessing hepatic vein flow. That's also a pulse wave. So you have to know what flow you need to use your pulse wave, and then what flow you need to use your continuous wave. TDI, so tissue Doppler imaging, where you actually look at the movement of the tissue, and it's the muscle. So you look at the movement of the muscle, say at the mitral annular or the tricuspid annular. That's also a pulse wave. Pulmonary vein flow, pulse wave Doppler. These are flow where the velocity is usually less than 2 meters per second. And then tricuspid inflow, just like mitral inflow, pulse wave Doppler. So any flow that is less than 2 meters per second, you can use pulse wave Doppler. And so this is mitral inflow. So mitral inflow is diastolic. So that's when blood is flowing from the left atrium across the mitral valve into the left ventricle. It's diastolic. The flow is towards the transducer. That's why it's above the baseline, right? So the flow is towards the transducer. The transducer is right up here. This is transducer. The blood is flowing from the left atrium across the mitral valve into the left ventricle towards the transducer. Hence, the flow is above the baseline. Okay, left ventricular flow tract. For chamber view, this is the sample volume. Your transducer is right here. The flow is from the left ventricle across the left ventricular flow tract into the aorta. It's moving away from the transducer, hence it's below the baseline. Hepatic vein. So in your subcostal view, you see your IVC, hepatic vein draining into the IVC. You just put your Doppler there, and if you remember the anatomy, it's moving away. It's moving away from the transducer, which is there. So it's below the baseline. And with the hepatic vein, you have a systolic component, you have a diastolic component, and an atrial reversal. So this is your ECG on top. Systole is from QRS to the T wave. Diastole is from the T wave to the QRS. So you have a systolic, a diastolic, and an atrial reversal. So if you think about it a little bit, so in systole, you know, the blood flows from the hepatic vein into the IVC. In diastole, it flows from the hepatic vein to the IVC. But when the atrium contracts, it pushes the blood in the opposite direction. So that's why it's above the baseline. So it pushes the blood in the opposite direction from the IVC back into the hepatic vein, so it's moving towards the transducer. So that's why this portion is above the baseline. Okay, tissue Doppler imaging. We actually put the Doppler, a sample, on the tissue, on the muscle. Okay, and our transducer is right up here. In systole, this moves up. So it moved towards the transducer since the systolic component is right there because the tissue moves up towards the transducer. And then in diastole, it moves downwards. So this would, in diastole, it moves, it sort of elongate downward. So we talk about E prime and A prime. So it's below the baseline because it's moving away from the transducer. So the tissue, in systole, it moves up, diastole, it moves down. So it do this. Okay? So if it's moving towards the transducer, it's going to be above the baseline. Move away from the transducer, below the baseline. Okay. And this is our pulmonary vein, remember? This is one pulmonary vein, another one is over there. This is our transducer. The blood is flowing from the pulmonary vein into the left atrium. So it's above the baseline. It's moving towards the transducer. So you have a systolic component, a diastolic component, but when the atrium contracts, it pushes blood backwards. So it moves away from the transducer. So you have a systolic, a diastolic, and an atrial reversal. Because when the atrium contracts, it pushes the blood back into the pulmonary vein, so it's moving away from the transducer. Any question there? So it all depends on whether the blood is moving towards or away from the transducer. Tricuspid inflow. So 4-chamber view on top. Tricuspid valve is right there. This is your RV and your RA. Transducer is right there. So in diastole, blood is moving from the right atrium across the tricuspid valve into the right ventricle. And so this is your tricuspid inflow. It's above the baseline. It's moving towards the transducer. Tricuspid inflow, moving. Same thing as the mitral inflow, moving towards the transducer. It's a diastolic flow. It occurs in diastole. All right, so important point. Pulse wave Doppler is limited by its inability to measure high blood flow velocities. So if you're looking at, say, shunts, valvular stenosis, or regurgitation, that velocity is too high to use pulse wave. Okay? You should only use it if you anticipate that the velocity is 1.5 or below. Or sometimes you can use up to 2 meters per second. So for low velocity flow, pulse wave Doppler, usually less than 2 meters per second. If you use pulse wave to measure higher velocities, you get something what you call aliasing. You get aliasing. And basically what it does is cut off, because it can only measure 2 meters per second, it cut off anything above that and put it below the baseline or above the baseline, depending on what type of flow. So if pulse wave Doppler with use high velocity, it's going to cause aliasing. Okay. All right. So aliasing is represented by the spectral trace as a cutoff of a given velocity because it can only measure up to 2 meters, and it looks like this. So if you were assessing aortic insufficiency, so aortic insufficiency is when you get a backflow of blood across the aortic valve. So the normal flow would be when the left ventricle contracts, blood flow across the left ventricular flow tract, across the aortic valve and into the ascending aorta. If you have aortic insufficiency, then blood is going to flow in diastole, blood is going to flow back across the aortic valve into the left ventricular flow tract and into the left ventricle. And it's usually a high flow. It's a diastolic flow. Aortic insufficiency is a diastolic flow. So what will happen? So if your EKG is on top here, okay? Diastole is from the T wave to the QRS, so this is diastole. So this would be your aortic insufficiency. This is your AI, but the pulse wave can only go to 2 meters per second. So it cut off what should be above there and put it below here. That's what we call aliasing. So up to about 2 meters per second, it goes up and then it put the rest at the bottom. Because it's not meant to measure anything more than 2 meters per second. So any high flow, high velocity situation, it's going to cause aliasing. If you have a high velocity, you need to go to CW, continuous wave Doppler. So for pulse wave Doppler, you will use it for low velocity flow. For high velocity flow, you use continuous wave Doppler. So, and for pulse wave, we use the symbol P Doppler. For continuous wave, C Doppler. So continuous wave Doppler measures blood flow velocity along the entire line of interrogation, not just as a single point, the entire line of interrogation. The transducer is continuously sending out pulse of ultrasound and continuously listening for the reflective frequency shift coming back. So it continuously sending out pulse and continuously receiving. So it's not limited by just sending out and then waiting and listening, continuously doing it. So it's sending and receiving at all times. It's used to measure high velocity flow. So anything above 1.5, 2 meters per second, you shift to continuous wave Doppler. Okay? So mitral regurgitation. So mitral regurgitation is when you have flow from the left ventricle across the mitral valve into the left atrium in systole. Because in systole, the mitral valve is supposed to be closed. But if the mitral valve is incompetent, that means it doesn't close properly in systole, then when the left ventricle contracts in systole, it's going to force blood across the mitral valve back into the left atrium. That's a systolic phenomenon. So if you analyze it right here, this is your 4-chamber on top. Your sample volume is across the mitral valve. Your transducer is right here. In systole, blood is flowing from the left ventricle across the mitral valve into the left atrium. It's moving away from the transducer, hence it's below the baseline, but it's each of these marking is 2 meters per second. It's much more than 2 meters per second, so you can't use pulse wave. You'll get aliasing. So we use continuous wave, which measures much larger velocity. Mitral regurgitation velocity is usually in the order of 5 meters per second or more. So you right away, you cannot use pulse wave Doppler. You have to use continuous wave Doppler for that. Tricuspid regurgitation, the same thing. You remember this is our short axis across the aortic valve. Transducer is right there. Tricuspid valve, right ventricular flow tract. right atrium. Tricuspid regurgitation occurs when the right ventricle contracts in systole. The tricuspid valve, for some reason, is not competent, so blood flow back across the tricuspid valve into the right atrium. It's a systolic phenomenon, but the blood is flowing away from the transducer, hence it's below the baseline. The flow in this case is about 3 meters per second, more than your 2 meters per second, so you use continuous wave Doppler. If you don't use continuous wave Doppler, you'll get ileocin, because pulse wave is only going to measure 1.5 to 2 meters per second velocity. Aortic stenosis again. So if the aortic valve is stenotic, it's not allowing blood to flow easily across the aortic valve into the ascending aorta, then you're going to get, so this is your transducer. It's a 4-chamber view right here. This is your aortic valve, okay? The sample volume is at the aortic valve, and blood usually flow from the left ventricle across the left ventricle flow tract, across the aortic valve into the ascending aorta. So it's moving away from the transducer. But because it's narrowed, the velocity is going to be very high. Just like if you guys must use your old-time hose to water your whatever. And if the nozzle is narrow, then it goes a long way, the velocity is increased. So same thing, if the aortic valve is stenotic, then the velocity is going to be very high. You cannot use pulse wave to measure that. You have to use continuous wave because it can be tremendous. In this case, so again, it's a systolic flow. It's moving away from the transducer. It's below the baseline, and this is up close to about 4 meters per second. You can't use pulse wave for that. Right? So continuous wave Doppler. All right. So some important points about continuous wave Doppler. Sorry. All right. No. All right. So let's look at color flow Doppler now. So as we mentioned before, color flow Doppler is a form of pulse wave Doppler. But what we did was we sort of separate the flow towards the transducer and the flow away from the transducer. We color code the flow. So the flow towards the transducer, we give it a color code of red. And then the flow away from the transducer, we give it a color code of blue. That's all it is. It's a pulse wave Doppler draw. So the returning echoes is displayed as an assigned color. Flow towards the transducer are seen as shades of red, and flow away from the transducer are seen as shades of blue. However, when you get turbulence, you'll get turbulence in any high velocity scenario, high flow scenarios. It is seen as a mosaic of many colors. It's a mixture of the colors. So when you have turbulence, okay? Remember, if your ultrasound beam is perpendicular to the moving red blood cells, the Doppler shift is 0. There is no flow, and no flow is seen as black. Nothing. You don't see anything. Okay? Faster velocities are displayed as brighter shades of red or blue. Okay? So that's your color flow. All right. Okay, so let's analyze what's going on right here. So your transducer is right here. Okay. If we have blood flowing from the left ventricle across the left ventricular flow tract, across the aortic valve, it's actually sort of moving towards the transducer. So that is why this looks mainly red. See that? So it's moving from the left ventricle flow tract, going into the ascending aorta. So and the transducer is there. So that's why it looks mainly red. In this case, this is mitral regurgitation. Blood is moving from the left ventricle across the mitral valve into the left atrium. It's actually moving away from the transducer, which is there. So it looks sort of blue, but if you look closely, it's a mosaic. It's because of turbulence. It's a mixture of the colors. And this shows turbulence even more because this is tricuspid regurgitation, short axis, tricuspid valve. Blood is moving from the right ventricular flow tract across the tricuspid valve into the right atrium. So the mosaic color, turbulence. See that? And then if you have aortic insufficiency now, in AI, transducer is there, blood is moving from the aorta across the aortic valve into the left ventricular flow tract and into left ventricle. Is moving away from the transducer. So it's mainly blue. So flow towards the transducer, going to give shades of red. Flow away from the transducer, shades of blue. Turbulence is a mosaic, a mixture of the color, you know. So that's Doppler in a nutshell. And I encourage you to go over this multiple times so that you know it sticks. I said before, it's not difficult, but you have to go over it.